There seems to be increasing interest in the subarea of hip microinstability and laxity about the hip. And so we wanted to get a biomechanical model developed so that we can study this in more detail in a scientific manner. Other studies looking at hip mechanics cut the ligaments of normal hips to see the consequence of cutting those ligaments. Those studies are helpful in determining the role of capsular ligamentous structures in hip motion, and some also included the evaluation of femoral head translation relative to the acetabulum. Yet those studies cut ligaments that were normal prior to the cutting. While this would help recreate microinstability as a result of arthroscopic capsulotomies, it may not replicate the other forms of microinstability, such as we see in dancers, gymnasts, and those with hypermobility disorders. We used 7 cadaveric pelvi with full femurs from young donors, those between 18 and 46, as this is the average age range of our hip arthroscopy population. We took radiographs to be sure that there was no prior surgery, avascular necrosis, osteoarthritis, fracture, dysplasia, or other deformity. The hips were cleared of soft tissue to the capsule and bone. We then marked the mechanical axis and recorded the version, and we mounted the pelvis on a custom apparatus in neutral alignment. The femur was rigidly attached to the actuator of the test machine with the femoral mechanical axis coaxial with the test machine's rotatory axis. The acetabulum was attached to the custom fixture that was allowed unrestricted motion in the axial plane during testing. Motion of the femoral head relative to the acetabulum was monitored throughout testing through the use of custom rigid body trackers mounted on the femur and pelvis. After preconditioning, we loaded the hip in both neutral and hyperextension for internal and external rotational arc, medial lateral translation, anterior posterior translation, and superior inferior translation. We then tested the translation with rotation fixed, both with the hip in anatomic neutral and biomechanical neutral positions. We used both positions to hopefully better understand the role of hip rotation and femoral head motion during flexion extension of the hip. After doing this with the capsule intact, we vented the capsule by placing an 18-gauge needle through the inferior capsule to remove negative intra-articular pressure. To create capsular laxity, specimens were oriented in a maximal extension externally rotated position with 30 Newton meters of torque for 100 cycles. So this was torque-based rotation. Then the specimens were loaded to the position of external rotation identified by the 100th cycle at 30 Newton meters for another 1,000 cycles. So this was then rotation controlled for these 1,000 cycles. A constant superiorly directed compressive load of 10 newtons was maintained during the cyclic stretching protocol. Measured testing states were baseline testing with the intact capsule, after venting, and after capsular laxity caused by our stretching protocol. After venting, we had an increased internal-external rotation range of motion in neutral alignment only and not in hyperextension. But we had a significantly greater degree of increased rotation when we tested both in neutral alignment and hyperextension after the capsule was stretched. Second, we found that femoral head displacement was increased relative to the vented state in the medial lateral, anterior posterior, and superior inferior planes after cyclic stretching of the anterior hip capsule in neutral alignment as compared to hyperextension. We were able to create a more physiologic model of hip microinstability in cadavers. This can allow for further work to understand hip biomechanics, pathomechanics, and ideally better ways to treat hip microinstability. So the development of this model was the first step into a series of future studies. We certainly want to look at the effect of intra-articular pathology like labral tears with and without capsular laxity on joint stability. And we also want to identify what is the optimal technique to perform capsular plication or gain stability of the hip without loss of motion.